So my name is Dr. Vlasis Ninios. I'm an interventional cardiologist in Balkan European Medical Center in Thessaloniki, Greece. And it's a great pleasure to present a step-by-step guide of how to perform transcatheter edge-to-edge repair in the tricuspid valve using the TriClip. So the objective of the procedure is to approximate the leaflets where the biggest gap is and where the regurgitant orifice is. Usually this is between the septal and the anterior leaflet, but quite frequently is between the septal and the posterior leaflet. The approach is usually from the right femoral vein, but it could be also from the left femoral vein, depending on the anatomy of the patient. After obtaining ultrasound guided puncture, we introduce the steerable guide sheath, the TriClip, that has the dual steering capability, and it's able to redirect the trajectory in the optimal fashion in order to facilitate the procedure. Through the TriClip steerable guide, TSGC, we introduce the TriClip delivery system, and we are able to flex it down to the tricuspid valve coming out from the inferior vena cava, and then obtain a trajectory which is alongside the long axis of the right ventricle. By opening the arms of the TriClip, we get a perpendicular direction of the arms to the line of coaptation between the respective leaflets that we want to grasp, the septal or anterior. And once we are happy with the procedure, with the position, we dive into the right ventricle. In order to obtain these views, we rely heavily on the transesophageal echocardiogram, usually using either mid to low esophageal views or transgastric views, facilitated by 3D MPR when is available and possible. The transgastric is key because by getting the device in the perpendicular fashion to the line of coaptation, we're able to get above the region of interest where the biggest gap and the regurgitant orifice jet arises, and then we're able to maintain this perpendicularity before grasping. The grasping is usually facilitated by the mid-esophageal views explained, or multi-D. We are able to introduce the leaflets usually one by one in the tricuspid valve, although traditionally has been a simultaneous grasping in the mitral space in the tricuspid valve. Because the leaflets are longer and because the gaps are bigger, we usually tend to grasp individual leaflets independently. So first we grasp the anterior leaflet, for example, or the lateral leaflet, and then we swing very slowly to the septal leaflet. We need to ensure that enough leaflet is getting inside the arms and the grippers are falling down, and we record the view before closing the clip slowly to ensure that the leaflets stay inside. Then we assess the result and of course the leaflet insertion by using multiple views, the same views that I mentioned before, and once we're happy with the result, we release the first clip. It's advisable to go from anterior to posterior because it's usually easier to visualize the second clip if that is positioned more posteriorly to the anterior clip. However, if the gap is, and this is rare, is the other way around, we can go from posterior to anterior, but the transgastric views can become a little bit more tricky and the imaging blurred. So if necessary, we can put a second clip between the posterior and the septal leaflet if there is a big gap, and this is a concept that works very well. This is the transcatheter clover technique, whereby we pull both anterior and posterior leaflets towards the septal leaflet, and that has been shown to remodel the tricuspid annulus. As we know, in most of the cases of atrial or even ventricular tricuspid functional regurgitation, the annulus is dilated outwards, and by pulling the lateral leaflets towards the septal leaflet, we're able to obtain a very good coaptation alongside the leaflets of the tricuspid valve, as well as annuloplasty effect. Thank you very much for your attention.